We'll go ahead and get started with our grand rounds today with Dr. Elsayed Soliman. It's my great pleasure to introduce Dr. Soliman. Dr. Soliman is currently a tenured professor of cardiology and epidemiology at Wake Forest University in North Carolina. He has extensive experience and expertise in the field of cardiovascular epidemiology and has published over 700 manuscripts in major medical journals. His research interests range from improving the current methods of recording ECG in population studies to developing new applications for the ECG data. Furthermore, he currently serves as the director of EPICARE, or the Epidemiological Cardiology Research Center, which is the ECG reading center for many NIH-funded studies, including ARIC, MESA, Accord, Cardia, to name a few. And Dr. Soliman has utilized data from these studies to develop novel ECG markers that are highly predictive of various cardiovascular diseases, such as heart failure, coronary artery disease, atrial fibrillation. And Dr. Soliman's work has reshaped the understanding of cardiovascular disease prevention and management, bridging population health insights with clinical practice. So we're very fortunate to have him fly all the way here from East Coast and join us today to give grand rounds. So welcome, Dr. Soliman. Thank you.
Good afternoon, everyone. It's a great honor to stand before all of you here in front of those people who are so committed to clinical research as well as caring of patients. Through many years, I have enjoyed intellectual discussions with many colleagues here. Greg Marcos, who's in Utah, skiing, not meeting with me, and Nora Goldschlager, while working with her as a co-editor on JAMA, and many brilliant mentees of both of them. So I really enjoyed lots of discussions. And Jeff Tyson this morning, David Mortara, lots of colleagues here that I really enjoyed lots of intellectual discussions and some disagreements that always ends by me being wrong. So today I will just continue this tradition of having discussions. So it is not like a dictation of what I know, but more of discussion of the atrial cardiopathy as a marker or a disease that expands the way that we look at atrial fibrillation as a risk factor for stroke. This topic intersects between clinical care and epidemiologic research. A few years ago, I did a very similar presentation. At that time, I had question mark after atrial fibrillation. At that time, we were actually asking, is it time to go beyond atrial fibrillation? Then after a couple of years after that presentation, I put exclamation mark. We were so excited that actually it is not about the question. It's clearly it is. And we have some data that supports that we should change the model and the atrial cardiopathy actually works. And we should go ahead with it. Today, I don't have question mark. I don't have exclamation. So it is just an open thing. Okay, and it is up to you to decide. And this is because now we have trials testing it. What could be the limitation of these trials? What do we want to do? This is what we will see during this presentation. So hopefully it will inspire some discussions, some ideas where we can go further. So the purpose of this presentation is basically first to understand the complexity of AFib stroke relationship, which triggered the whole idea of looking at atrial cardiopathy as a model that could replace the association between AFib and the stroke, and then recognize the role of atrial cardiopathy as a model that could explain some of the cardioembolic stroke. And we will utilize some data from the current practice guidelines and statements to support some of the arguments, or to see how really some of what is going on shaped some of the current practice guidelines and the statements. And finally, identify some gaps in knowledge, future directions, which could actually trigger some research opportunities for some of you. So how we go about that? We will start with a clinical case. It's mainly neurology case. It's a stroke case that I got from one of my colleagues, Chagiyag. So, and looking at AFib stroke relationship as we know it, and what could be the problems with it, or why it is not convincing as we thought it is. Then talking about atrial cardiopathy. What do we mean by atrial cardiopathy? How we started actually talking about atrial cardiopathy. This term has been there for 1976 or something, but actually it didn't really came up so common for people until a few years ago when there was a statement by the European colleagues about it. But actually we had lots of work before that. And we didn't name it atrial cardiopathy until Arcadia trial that came later on, which I will talk about it as a way of implementation, and also other trials that looked at that concept. Then we will end by conclusion, and if you have questions. So let us start with a case, 76 years old, happened to him acute onset of aphasia, right-sided weakness, occurred 1 hour before he arrived to the ER. Before that, he was okay. Nothing really in his medical history, except having hypertension, and either from his medical history and from the family history, nothing really except that. But pressure goes with what he stated as having hypertension. Heart rate was regular. He doesn't have AFib. His NIH stroke score 22, which is a total out of total 42. So he's, according to this score, is actually severe stroke. And this is for left middle cerebral artery syndrome. They did CT, non-contrast CT. The first picture shows no hemorrhage, which is important to start treatment. Second one shows here left parietal loop infarction, and the third one showed cutoff of the M1 branch of MCA. So based on that, they start him on RTPA, and they did thrombectomy to him. He improved. And after that, during this process, they did some investigations. It looks like something embolic, but they couldn't prove it. So they did echo, they did telemetry, but it was negative for AFib. His BNP was high. They did lots of investigations to look for what could be a source for what seemed like there is embolic stroke. They couldn't find anything. So they start him on antiplatelet according to the guidelines, but during follow-up, they put him on 30-day cardiac monitor, still didn't show any AFib. They put implanted cardiac monitor, and it showed 2 hours of AFib after 8 months of the initial stroke. And at that point, they changed the treatment from antiplatelet, from aspirin, to anticoagulant. He didn't have any recurrent stroke after that. Okay? So basically, this is a typical case of cryptogenic stroke. He came, they didn't know what this could be. It looks like embolic, but they couldn't find the source. They put him on monitors to identify the source. So in terms of definition, this is cryptogenic, which has a subclassification of being ESUS or embolic stroke of undetermined source, which is basically what it means is that they did everything possible to identify the cause of that cryptogenic stroke, but they couldn't identify the source of emboli. So this is cryptogenic stroke. You can call it as such. You can call it ESUS. You can call it as such, but it is mainly ESUS. So what? He did everything good. He was treated per guidelines. Everything was perfect for that patient. In early management, he was assessed using NIH stroke score. It is class of recommendation 1, and level of evidence, it is not that good, but it is still good compared to others. So he got everything according to the guidelines. So he was assessed very nicely during the acute phase, and everything here, class of recommendation is 1. They checked him by ECG. They did everything. And during the follow-up, the same way, they put him into a monitor. They couldn't give him anticoagulants, which also no benefit. If you start giving people empirically, just give anticoagulant because you think that it's embolic. But once AFib was detected, you have to give anticoagulant, and this is what happened to him. So really, this guy got the best treatment according to the guidelines. So what is the problem here? Why some people could be complaining? The problem here is that we have lots of these cases, almost 250,000 cases of ischemic stroke every year are classified as such as cryptogenic strokes. So having a name for it doesn't solve the problem. Saying it, it's cryptogenic stroke, that's not a diagnosis, this doesn't help people. And 50% are still ESUS. That is to say, they did everything to find out the source of what seemed like to be cardioembolic, or there's a source of emboli there, but it is not. What even more is something like this patient, 30% of those ESUS patients eventually show AFib during the long-term monitoring. And we know that AFib increases the risk of stroke 5 times. And once they get anticoagulant, that risk reverses most of it. We are not saying here, or it is not necessarily, that AFib that happened after 8 months is the cause of the first stroke. But at least it could be the cause of a second stroke. That's why they started giving anticoagulant. But it looked like embolic stroke, that there is a source of a stroke, and the patient is getting AFib. Could be paroxysmal AFib that was not detected. Could be a disease that caused stroke, embolic stroke, a thrombus somewhere, and it is the same disease that led to AFib later. Could be anything. But the fact is, we got this patient having AFib after 8 months, and it looked like embolic stroke. So if it walks like a duck, walks like a duck, probably it's a duck. But the problem here is, if we start giving those people anticoagulant empirically for all cryptogenic stroke or all ESUS, anticoagulants, actually it doesn't work. Actually, it is not better than aspirin, according to guidelines. So probably we will have to wait until AFib starts. But if we wait until AFib detected, some people actually will get recurrent stroke before we detect it. So something here not right, or at least it is the relationship between AFib and the stroke is more complex than we thought. So how is this? So let us look at it. There are three issues between AFib stroke relationships that probably I can just talk about, and I will limit the talk about those three things. The temporality issue, which is chicken egg issue, which one happens first? If really AFib is a cause, it should happen before, and it shouldn't happen after. And the response to treatment, and also the disconnection between rhythm and the outcomes. So, as I said, our patient his AFib happened after, not before. But as I said, maybe it is just a coincidence. Maybe it's paroxysmal AFib. Maybe it's a disease, blah, 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 blah. It could be anything that you want to say, okay? Is there any evidence from other studies? Yeah. So let us look at a search study. A search study looked at subclinical episodes of rapid atrial rate detected by implanted devices and whether associated with increased risk of ischemic stroke in patients who did not have evidence of atrial fibrillation before. So those people have been, as if they are always monitored for AFib or atrial arrhythmias, and we will know when they will get stroke. 2,580 pacemaker patients, followed for 2.5 years, 51 ischemic stroke happened. 16% occurred after AFib of the events. 49 events occurred without AFib at all. So they looked like still embolic. 35% occurred before AFib. So 35% of a stroke happened before AFib. Is this a coincidence? Well, there is another study, IMPACT, which tested the hypothesis that introduction and termination of anticoagulation based upon atrial arrhythmia monitoring would reduce risk of stroke and bleeding. Found the same. People were followed up, 2,700 people for 2 years, 69 thromboembolic events. 29 of these events happened after AFib, which, okay, but 58 events occurred without AFib, and 13% happened before AFib. The same for trends, which looked that more atrial fibrillation will be associated with more risk of strokes. And those people, events happened, 50% happened before AFib. So stroke happening before AFib doesn't go with AFib really causing stroke. So the causality here is questionable. And this is what I mean, that we have the issue of temporality, at least we need to question the temporality association between atrial fibrillation and stroke. How about the response to treatment? Do we get the same effect if we start giving people anticoagulant? Well, crystal AFib, which looked, how as long-term monitoring versus just standard care of patients will detect more AFib in cryptogenic stroke, and then giving appropriate anticoagulation. Actually, they didn't find any difference whether you long-term them and identify more AFib and give anticoagulation is no different from just do whatever you can. The same for finding AFib. Maybe the studies, maybe it was underpowered, maybe AFib definition in these studies were only 30 seconds, based on 30 seconds of AFib. Maybe it was a bit short, but actually this is the way that most of long-term ECG recording identifies AFib. One of the statements, that said, okay, actually there is evidence that, the longer AFib, the more risk, and probably there is a threshold, but we don't know the threshold. So not all AFib are AFib or equal. Not all AFib are equal. in terms of association with a stroke. But why they are not equal? What do they represent? Maybe they are representing something else other than just a rhythm. How about the association or the impact of anticoagulation based on the length or the duration of AFib? In this study, they looked at atrial fibrillation for 6 minutes, atrial fibrillation for 1 hour, atrial fibrillation 6 hours, and 24 hours. And they start to give people anticoagulants. Only the one that is greater than 24 hours, atrial fibrillation detected in these long-term monitors, greater than 24 hours, is the one that really anticoagulants really prevented stroke. Less than that, not really helping those people. So even with atrial fibrillation greater than 1 hour, so the effect of treatment is really not the same for the same atrial fibrillation. Where did it go with the mouse? And this really changed some of the guidelines for ACC and AHA guidelines for diagnosis and the management of AFib. Currently, there is no benefit of giving a device-detected AFib less than 5 minutes. And the benefit, although it is a bit weak, it is only for people greater than 24 hours. So really, this changed the way that we look at AFib. How about the disconnection between rhythm and order? We need stasis, we need hypercoagulative state, we need endothelial damage. So if the arrhythmia is the only cause of thromboembolism, shouldn't it be converting to sinus rhythm should eliminate the risk? Actually, this is not the case, as I will show in the next slide. And also, there's marked differences in the stroke by CHA2DS2-VASc score. Why? It depends on underlying atrial pathology. Shouldn't be just AFib, but here in this study from atresia, only we show here it is impacted. I don't know, the mouse stopped working, but you see here, and when it CHA2DS2-VASc greater than 4, it actually starts working. The anticoagulants start to work only when CHA2DS2-VASc is greater than 4. When it is less than that, really anticoagulants is not working as it should be. So the effect of treatment is also not the same. And here is a meta-analysis looking at rate versus rhythm control and how this could impact the risk of stroke. No difference between rate and rhythm. Whether you control rate, you control rhythm, the risk of stroke is equal. So the rhythm is not the issue. However, there is recent data that shows that if you start converting the rhythm very early, you get some benefit of prevention of stroke. So this is different a bit from what I just said. So if you wait to convert it to the rhythm, probably the rate versus rhythm, there is no difference in prevention of stroke. But if you do it early, probably there is some benefit. So this means that you are changing something in the atrium or the disease when you do a rhythm early on. And this changed some of the guidelines to recommend early intervention or early ablation for people with atrial fibrillation because it can some changes in the atrium. And this supports that there is something. So it is not only about the risk. So what does this mean really? So now we have a complex or non-convincing relationship between atrial fibrillation and stroke. So what? Again, we have a problem because we have a problem. We have many people are getting cryptogenic stroke that looks like embolic stroke that we think that it could be related to atrial fibrillation. Probably it's related to the atrium or atrial disease. There is something going on that causes embolism from the heart. And when we need to treat those people with a stroke, even if we manage them, 50% remain with hemiparesis, 30% remain with weakness of at least one limb. Over half of them remain with cognitive decline. A quarter of them still needs help with someone. They are dependent on someone at home. Quarter of them end in nursing homes. So it is a big problem, and we need to sort it out. That's why we need a model that probably explains some of these inconsistencies. And we need to identify people who could probably benefit from something like that. So that's why, a few years ago, we start to, suggest that maybe it is not really atrial fibrillation as a reason. It is the atrial disease. So instead of having atrial disease leading to atrial fibrillations in ischemic stroke, it is all cascade of atrial disease. It is one thing. And the atrial fibrillation is just part of that cascade of abnormalities that happens within the atrium. We can call it atrial cardiopathy. Atrial cardiopathy as a term has been going on, as I said, sporadically using 1970s, but really not in terms of the relationship to outcomes. It was mainly just, going on as an entity, as a disease, as relating to conduction abnormality, something like that, but not relating it to stroke or an outcome per se. But here we're talking about that here atrial cardiopathy is a disease that impacts the atria. Atrial fibrillation is part of that. AFib is not a standalone. So here, AFib is not a standalone disease, but a marker and a part of that atrial disease continuum. And the duration of AFib, which as I showed that, that duration differs in terms of association with a stroke, and also the link to anticoagulant is different. The duration of AFib, basically, it reflects the severity of atrial disease. And the arrhythmia itself is not the cause of thromboembolism. It is a manifestation of atrial disease. So early on, even before having that statement from the European colleagues, we presented our views in future cardiology, and we had lots of publications about that term. We tried to use atrial cardiopathy because it was used before. We tried to use atrial myopathy, but actually before that, all the supporting evidence, we didn't use any of these terms until we start to use it in review articles. At that time, we defined as any ECG or non-ECG. Why ECG? Because I'm leading an ECG course. So, and most of the evidence at that time, we got it from the ECG markers. So defining at that time, 10 years ago, as all ECG and non-ECG markers reflecting atrial abnormality could be part of that spectrum, what we called it atrial cardiopathy. But the strength of association to stroke could be different, which is important to understand that, because how much of risk of a stroke that justifies getting anticoagulant, which is critical piece, so that later on, if we want to give those people anticoagulant, really we have to pick the right markers of atrial cardiopathy and the right severity of atrial cardiopathy. Later on, heart rhythm and the Europeans also, they did their statement finally, and Greg Marcus here was part of it. And then they updated it only 1 year after. They were in a rush to update, although none of them actually were part of what we did in stroke, by the way. So most of the work was done by Human Kamel from Cornell, Mitch Eklund, who was also in Colombia, and then he led the AHA later on. And they define it mainly from the perspective of electrophysiologists, as any complex structural, contractile, electrophysiological changes affecting atria and potential reduced clinical relevant manifestation. It's a very nice document in terms of electrophysiology and what cardiomyopathy represent. But really, it lacks association with outcomes. They did actually classification as subclinical and the clinical and atrial, but none of them really is linked to outcomes. how much of this mild or subclinical relates to outcome, how much of that clinical, which is including AFib, by the way, relates to outcome. Because even within subclinical, clinically, for example, you have BNP. BNP could be actually very high and could lead to stroke. Actually, it's non-specific. That's a bad example, but could be atrial fibrillation, for example, as we show it. That longer duration of AFib could be very bad and could be reflecting severe. So none of this was really tested as related to outcomes. So how did we prove that concept of atrial cardiopathy? To prove it, it came to, okay, could atrial substrate, before developing atrial fibrillation, could lead to stroke? That was the first step that we wanted to test it. If we look at this model, if we have genetic predisposition to atrial fibrillation, then you have age, disease-related remodeling, which is that color. I think this is pink or violet or whatever, purple, very bad in colors. That develops, that keeps going on through the years, which from the x-axis. And you have the AFib remodeling that actually happens once you start to have the paroxysmal AFib. So the question is, could you really get stroke before getting into paroxysmal AFib? Can any of these substrates before that causes a stroke without really getting into AFib? And if this is true, it means that probably you can manage those people, get intervention, and the concept of having a spectrum is correct. So there have been lots of variables that people looked at it, and some related to whatever the definition came in that heart rhythm statement. And the one that we really started is the P-wave morphology and the P-wave terminal force. And I will explain it later on. And anything from ECG, so could be paroxysmal, supraventricular tachycardia, could be atrial ectopic beats, some from echoes, it's like left atrial size, and some from lab. P-terminal force, originally, it's a very old marker. And it's used originally to reflect left atrial size or left atrial enlargement. But actually, it could be, increased filling, when you have diastolic dysfunction, it could be increased filling of left atrium. But it could be also, conduction in the left atrium, that small bundle between left atrium and right atrium is not working well. So it could be actually lots of things. And we did the first paper, and in that one, we called these markers actually predictors of atrial fibrillation. We didn't call it atrial cardiopathy. And the purpose of this paper actually was not really looking at cardiopathy per se. It was mainly to look at racial differences and how it could explain atrial fibrillation. So in this paper, although we looked at P-wave duration, P-wave area, we looked at lots of markers of P-wave. The one that stuck out was P-wave terminal force. It's 15,000 participants from ARIC. They were free of stroke at baseline, and P-terminal force in V1 was measured from the digital ECG. P-terminal force in V1 is multiplication of the amplitude and the duration of the second P in the ECG. And we looked at ischemic stroke without differentiation between the types. And it was associated with 22% increase in ischemic stroke. At that time, I didn't know my colleague Homan Kamel from Cornell or Mitch Eklund or any of the stroke folks. But after that, we start to work together on more papers examining these markers. And we start to look, okay, so we have MRI in another study. It's older people, 65 years old. So let us just look at how this marker really replicate. It's about 3,000 people. It's older folks. Again, digital ECGs. And we adjust for everything and the brain infarcts and wide grade. We looked at two ways, looking at prevalence and the incident. And we looked at any infarct and the non-lacunar. Non-lacunar, it is, it's more suggestive of being embolic or cardioembolic, and here we found that it is associated with any infarct and the non-lacunar in the association of prevalence. Incidence, it didn't reach statistical significance, but the sample was too small. But we adjusted for incident atrial fibrillation. So we know that the association doesn't go through the atrial fibrillation track. We did the same in another study in MESA. We found the same results. We said, okay, so let us look at types. We looked at types, and we found that lacunar, it's not associated. Non-lacunar, it is associated, and no change after adjusting for atrial fibrillation, and the association goes linear, as I am showing in this stage. So at that time, we said, oh yeah, but all digital ECGs, not everyone has digital ECGs. Can we measure it from paper ECG? Just ECG, and the clinician can just measure these P-terminal forces themselves. We found actually it works still. So this is in Northern Manhattan study. They don't have digital ECGs, it works the same. So we tested on other markers, period duration, other, atrial arrhythmias. We found that they are all associated with a stroke. Maybe not the same as P-terminal force, but the principle stands that any ECG marker that could reflect atrial disease is associated with the risk of stroke. Imaging, there are different modalities, echo, CT, MRI, they are different in what could be measured, and as this table shows, it could be showing what could be measured. Association with outcomes, it's pretty much similar to P-terminal force, but none of these studies really adjusted for atrial fibrillation. So we got really convinced that something is going on. We extended it to blood biomarkers, to BNP and others, but there are specificity issue with some of these markers, but it goes, especially with BNP. So we had it. But all of this just proves that the atrial substrate can lead to stroke without atrial fibrillation. We need to apply to patients. If we give people anticoagulants, would it help? That is the real thing. So, and that is the question that kept being posed after we start to have these review articles, pushing for the idea. Is that a useful thing or just something that's going on and people ask it for a trial? And actually, we were trying to push for funding from agencies. So at that time, there was actually a trial called Navigate ESUS. They looked at NOAC versus aspirin in all ESUS. People that looks like embolic stroke, looks like cardioembolic, and they said, let us give all of them anticoagulant. It didn't work. But when they added one of the measures of atrial cardiopathy, it worked. So it showed that benefit of giving anticoagulant to a subset of people with ESUS when you give them anticoagulant. And a similar benefit was found also in another small study. And that was good time to put an exclamation mark to that question going beyond atrial fibrillation, because we have some positive results here. And at that time, Arcadia started 2016. So our study will be going on and proving the final thing, because these are secondary ad hoc analysis. But later on, another study came, and they did dilated left atrium and atrial runs using CHADS-VASc. So really, they are having some measures of atrial cardiopathy, and it was early terminated because of no benefit. So I had to remove the exclamation mark. So not exciting anymore. But we were hoping that Arcadia will just, we had a better markers. We have P-terminal force, which we were just hitting on it. And we have a combination of blood biomarkers, P-terminal ECG markers, and echo markers. So probably we are better. So we will see what happens. And this is how we started the Arcadia trial. My center was the leading center for it, doing the ECG. Arcadia was randomized, double-blind, multi-center clinical trial. It is biomarker-driven. Apixaban versus aspirin in those people with cryptogenic stroke, plus atrial cardiopathy, which I will show you how it was measured in the study. 185 sites from NIH StrokeNet, and it was funded by the NIH and the Institute of Neurological Disease, and it was supported by the free medications from Pfizer and Bristol Myers. The definition of atrial cardiopathy in the trial was P-terminal force in V1 greater than 5,000. Usually we use 4,000, but we wanted to be more specific, so we used 5,000, and BNP greater than 250, and left atrial size greater than 3 centimeters using echo. This is the enrollment after excluding people with atrial fibrillation, not eligible, and after screened people, almost a lot of people, 3,700, more than 3,700. It ended to be 1,000 after having all the exclusions and being selective, ended up to having 500 in each arm. How people selected based on this criteria, most people actually came from the P-terminal force and from proBNP. Only very few came, only 13 from echo, from those people from cryptogenic stroke. So the number of people enrolled based on echo is very, very small. Most people enrolled based on ECG and based on proBNP. So meaning that most people with cryptogenic stroke that enrolled were having either ECG abnormality or proBNP. This is the baseline characteristics. It's mainly balanced between the two groups. Nothing really here that could be, drawing any attention, except that people really having 20% having the prior stroke, but everything was really balanced, which means that the randomization was good. So there is no issue with randomization. Fortunately, there was no difference. Aspirin was apixaban, and at that time we had not just removed the exclamation mark, but we had to put a sad face for the results. And if we look at the, in terms of a table, the primary outcome, no difference. As you can see, the hazard ratio is 1, and the secondary outcomes also nothing. But there is no safety concern. And actually, if we want to look, actually, the safety concerns, the apixaban even, having less side effects, actually less hemorrhage, minus 1.1. I don't know what happened to the mouse. I can't point it, but it is that major hemorrhage, that 0.9. That's okay. Yeah, so it is minus 1.1. That is difference percentage. This one, you see there that actually it was better in apixaban. So, and then let us not to forget that's actually you're comparing. It's not really, there is no benefit of apixaban. It is no different from aspirin. Okay, but here also we are saying that actually apixaban, reduced the hemorrhage. Or aspirin was having more hemorrhage than apixaban. Whether this justifies anything or not, I don't think so. The cost doesn't justify that small benefit anyway. The subgroup analysis, we start to look at subgroups. Although as someone who sometimes teach clinical trials, we shouldn't do actually subgroups if the main results are negative. But here's the subgroups. Nothing really sticks out. Of course, they did the unadjusted and the adjusted. Some of the subgroups here, it looks like very close to significant, but this is the unadjusted. By looking at the LA size, it tends to be as if apixaban is okay, and the same for P-terminal force. So both favors the apixaban. If you look at P-terminal force in people with high P-terminal force and people with high left atrial diameter. So there is signs of being good, but again, nothing reached statistical significance, at least using the 0.05, and this is unadjusted B value, not looking for multiple comparisons, but looking at multiple comparisons, nothing even close to being significant. So nothing in the subgroups, and if you look at sex differences, it is significant in the unadjusted, but nothing really in the unadjusted. Sorry, in the adjusted. So we try to look, what could be, what happened? Maybe it's not the right atrial cardiopathy markers. We know that the fundamentals are right, but maybe we used wrong or in not enough biomarkers for atrial cardiopathy. Maybe the cutoff is not good. Maybe because AFib screening, because we have to shift people to treatment once they discover AFib. Maybe they develop atherosclerosis, maybe suboptimal adherence to drugs. It is up to you to think also, what went wrong? Why the study was not there? So the question really, so now I had to put back the question mark. So it's time to go beyond atrial fibrillation and have that model for atrial cardiopathy. Yes, to me still the answer is yes. There is mounting evidence that there is a growth thrombotic atrial substrate there, before atrial fibrillation happens. And this could either promote atrial fibrillation, and also it could lead to stroke. And if we intervene to people at that time, probably we can save lives. But the point is what markers we need to use. And this is one of the gaps of knowledge that probably all of us should think, or at least people who cares about that. And I hope some of you will be, that we need to get more specific markers of atrial cardiopathy. Either ECG, either blood biomarkers, either from imaging, either from combination of all. We need to understand more about atrial cardiopathy. The risk factors, how we got there from atrial cardiopathy. The classification of severity, which is important. As we showed even with atrial fibrillation, not atrial fibrillation are equal. 24 hours atrial fibrillation is getting better with anticoagulants. 30 seconds atrial fibrillation not associated with a stroke as it should be. So this applies the same for atrial cardiopathy. So we should identify or define severity somehow, and how severe that could be associated with a stroke, and how severe that could be benefiting from anticoagulants. And this leads to identifying those at high risk of atrial cardiopathy that could be really benefiting from anticoagulants. And what really is a temporal relationship between these different atrial cardiopathy markers? What is the relationship between increase in atrial size and B-terminal force and BNP? And so what happens before, which happens before what? And the relationship between each one of these things, so that when we pick our atrial cardiopathy markers, we don't pick repeated markers that could be really, we are repeating ourselves. And we need to pick markers that could add it to each other. And if we have to repeat them, it is mainly to make sure that we are validating them. And what could be the prevention treatment? What measures that we can use to prevent and treat atrial cardiopathy? What measures, that we can add to treat atrial cardiopathy? People with obesity, we know that they have some diastolic dysfunction and they could get atrial cardiopathy. But GLP-1 could help, maybe. How about, not using anticoagulant, maybe using factor 11? Help? Does it help? How about, defining risk factors, combination of risk factors? Does it help? Do we have differences among among treatments for hypertension? So we need to really think about what could be done in terms of atrial cardiopathy. We don't have specific actually preventive measure for atrial fibrillation, but probably we can have some preventive measure for atriopathy. Then we have others that I did not touch on, about the racial differences. We have the atrial fibrillation paradox. Blacks have more risk factors, but they have less atrial fibrillation compared to whites. Well, actually, atrial cardiopathy has also its own paradox. Preterminal force is actually more abnormal in African Americans, but they have whites have larger atrial size. Now you have discrepancy between two markers that used to be, related to each other. So even these markers sometimes it goes against each other. If you start to look at racial differences, I didn't touch it on here. I don't want to go into that. What is the role of AI, machine learning, deep learning? Maybe we can just use some of these, to get a better sense of what is going on instead of depending on one marker. If these grassroots markers. So I will end here by the conclusions, giving you some few minutes to have questions. So that atrial cardiopathy is basically a model which is not a standalone disease, but it's more of a continuum of atrial disease. And the risk of stroke can exist at any stage, but of course with different levels of association of disease. And that atrial cardiopathy model actually, resolves that inconsistency in the relationship between AFib and the stroke. And this could explain why having AFib after stroke, it would be basically atrial cardiopathy earlier on that could be extended to being atrial fibrillation after stroke. And atrial cardiopathy could potentially prevent more strokes by identifying a new high-risk group. But it is our job to identify, how we identify those people. And really gaps of knowledge exist, and this creates opportunity for discovery. I will stop here, and I think we have a few minutes for questions in case you have some. Thank you.
Dr. Soliman, for a great talk. I'm just going to change the layout here so we can see the people on Zoom. And I know there's, I see